It's my immense pleasure now to invite Dr. Vinni Makin. And Vinni is a good friend of mine and also a practicing endocrinologist. She's a director of the endocrinology on the East Side. And she's a fellow of American College of Endocrinology. She's very much involved in the curriculum development and medical education. The topic that Dr. Makin is going to talk today is very interesting, the management of inpatient and outpatient diabetes mellitus in the COVID-19, because as you know, most of these telemedicine and telehealth because of this pandemic is a challenge for the patients who have a chronic morbidities and mortality. And it's hard, especially with blood pressures, with CKD, and diabetes is a very integral part of that. So this will be a very educational webinar, and followed with that will be Dr. Prakash Chand. So I'll welcome Dr. Vinni Makin, and Dr. Vinni Makin is also part of our education and research in EPNO, and she's our executive member. Dr. Makin.
Thank you so much, Rupesh, for that kind introduction. I'm going to talk about diabetes management in the era of novel SARS-CoV-2 virus pandemic today. So the outline of the presentation is going to be, we're going to talk about diabetes as a risk factor for complications for infection. We're going to talk about all the challenges in the management of outpatient and inpatient diabetes. How are we managing remote monitoring of both inpatient and outpatient diabetes at this point? And at the end, I'm going to talk a little bit about obesity as a risk factor for infection, as well as the changes in management that have happened recently because of the pandemic. So we already know that diabetes leads to increased susceptibility to viral infections. In fact, there's existing data that patients with diabetes did worse during previous viral epidemics, like the SARS epidemic, the Middle East respiratory virus epidemic, and the H1N1 influenza. On the right of the screen, you can see this 2003 study from JAMA, which was, sorry, okay. On the right of the screen, you can see the 2003 study from JAMA of 141 hospitalized patients in Toronto with SARS-CoV at the time, and they show clearly a threefold increase in mortality in patients with diabetes. Here is a retrospective study for COVID-positive hospitalized patients in China. This was about 1590 patients with a case fatality rate of about 3.14%, turns out to be about 50 patients. And the prevalence of diabetes among the fatalities was about 26%, which is second only to hypertension in terms of existing comorbidities in the fatality. This is another study that came out in the NEJM, and this was from the China Medical Treatment Expert Group for COVID-19. They looked at 1,099 patients with laboratory confirmed COVID-19 disease with primary endpoints of admission to ICU, need for mechanical ventilation, or death. And here you can see that diabetes was present in about 7.4% of the total population. But when you look at, in terms of percentage in severe and non-severe disease, 16.2% of the patients with severe disease had diabetes. When you look at the primary composite endpoint, 26.9% had diabetes. So this tells you that about a threefold increase in terms of attaining the primary composite endpoint in patients with diabetes versus in the general population. This is from the Chinese CDC, and they looked at a total of 72,000 cases as of February 11, 2020, out of which 44,000 were confirmed, and there were a few suspected, diagnosed, and asymptomatic cases. The case fatality rate was in the confirmed cases was 2.3%, while if you look at those with diabetes was 7.3%, which tells you that there was again a threefold higher percentage in terms of mortality in patients with diabetes as compared to the general population. Now, what are we seeing in terms of laboratory parameters in these patients? So this is another study that came out of Wuhan Hospital. 174 consecutive patients who were hospitalized, out of which 37 had diabetes. Their inclusion criteria was an epidemiology history, fever, typical CT image abnormalities, or a positive result of RT-PCR. middle-aged population, out of which 43.7% were men in this. Here's a look at their laboratory markers. So A is their blood counts, B is inflammatory markers, and C are markers of coagulation. And here you can see clearly that patients with COVID-19 infection tended to do worse in terms of these inflammatory markers, especially ESR, IL-6, C-reactive proteins, serum ferritin, D dimers, and so on. So this gives you an idea of why we are seeing worse complications, because we are seeing much higher inflammatory markers like IL-6, leading to a cytokine storm in patients with diabetes versus who don't have diabetes in this population. What are the causes that we are looking at for this? So the thought is patients with diabetes do tend to have defects in innate immunity, which affects phagocytosis, neutrophil chemotaxis, as well as cell-mediated immunity. We do know that patients with diabetes tend to be older, and we know that age is an independent risk factor for complications from novel SARS-CoV-2 infection. We also know that patients with diabetes tend to have a higher prevalence of cardiovascular disease, which in turn leads them to a higher risk of cardiovascular complications from infection. Hopefully, I've convinced you at this point that diabetes is clearly a risk factor for developing complications from COVID infection. Now, what are the challenges in the management of inpatient diabetes that we are seeing? One is the lack of adequate personal protective equipment. I don't think I need to say more about this, but there has been enough written and talked about in the media about this. There's clearly a lack of adequate trained caregivers. I know Cleveland Clinic has sent caregivers over to New York as well as Detroit and are asking for volunteers for Abu Dhabi at this point. We know that patients with diabetes tend to be in a chronic inflammatory state. And as I showed in the data before, they have an increased susceptibility to viral infections in general. There's insulin resistance during the stress state. A little comment about that. We see insulin resistance in all stress states. We often see insulin resistance in patients who are admitted to the hospital for surgeries. But the observation in COVID positive patients has been a little bit different. Their requirements of insulin are going into hundreds of units of insulin a day. So that resistance we are seeing is so much more than what you would see in a stress state coming from other reasons for hospitalization. Use of steroids. Before, I think we had data, there was stress dose steroids were being used in these patients to hopefully improve outcomes, and that by itself will increase, will complicate diabetes management. And the last thing we are seeing signs of possible pancreatic islet cell destruction in these patients as well. So there are lots of challenges in the management of inpatient diabetes in these patients. So what are we using as management strategies? The first thing we are using is something called the Freestyle Libre program. So I'll go into details about this, but I'm sure all of you are familiar with the Freestyle Libre, which is a continuous glucose monitor that goes onto the skin and is approved for use for both type 1 and type 2 diabetes. Use of subcutaneous DKA protocols. Currently, intravenous insulin is considered the standard of care, but a lot of hospitals are trying to use subcutaneous DKA protocols because they help with bundling of care and decreased frequency of fingerstick blood glucose checks. And the last thing we try to use is oral anti-hyperglycemic drugs, again to the same aim of bundling care and decreasing frequency of finger sticks. So you are decreasing the number of times nursing is going into the room and getting exposed to the virus. So this was a game changer in the area of inpatient diabetes management. Till April 8th, there was no continuous glucose monitor that was approved for inpatient diabetes management. We have a lot of patients who have CGMs, again, that's the short form of continuous glucose monitors. The two kinds that are on the market are Dexcom and the Freestyle Libre, but none of them are approved for use inpatient. So when patients come in who are using this, we usually either take them off or they can elect to keep them on, but we continue doing finger sticks on them. On April 8th, FDA approved the Libre program, the 14-day system, to be used inpatient as well. And Abbott, which makes the Freestyle Libre in partnership with the American Diabetes Association, decided to donate 25,000 sensors to US hospitals and medical centers in outbreak hotspots. So this gives you an idea of how this is used. So this is a picture of Theresa May, who was the previous Prime Minister of UK. And on the arm, you see this little disc device. That is the Libre. So the way it works is this Libre goes on for 14 days and it stays on. It has a sticky thing. It stays on when you take a shower, exercise, swim, all of that. And you can either scan it with a little reader device that looks like a pager, or you can scan it with a smartphone, and that will tell you what the blood sugar looks like. You can scan it as often as you want. I have patients who like to see what their food is doing, so they scan it very often, or you can scan it at least every 8 hours to make sure you have readings in between as well. So the Freestyle Libre was actually rolled out at the Cleveland Clinic a few days ago, and the first sensor was inserted at main campus in a SARS-CoV-2 positive patient. The way this is going to work is that the patient can tell the scan reading to the nurse. They can either use the reader or their own smartphone for doing this. The reader does not, but the smartphone can wirelessly transmit data for downloading remotely. But this basically decreases the finger sticks that the nurse has to do because the patient can do the reading themselves. So this was a great improvement in inpatient diabetes management for these patients. The other changes that have been done in management, one is the basal bolus therapy. So we talked a little bit about the fact that insulin therapy is considered standard. We are trying to kind of find a good balance between using oral hypoglycemic agents, but we are also using basal bolus therapy because of their insulin requirements. As I mentioned before, we are doing subcutaneous insulin DK protocols. Unfortunately, they can only be used for mild uncomplicated DK, not for severe DK, but they really do help with bundling of care. Because in IV insulin protocols, the nurse has to check finger sticks every hour and titrate insulin. But for subcutaneous insulin DK protocols, you can decrease the frequency of finger checks to once every 2 or 3 hours. This is a slide. I'm not going to go over the protocols per se, but these are resources from the American Diabetes Association. This talks about the standard basal bolus insulin protocols as well as subcutaneous DK protocols. On the bottom of this slide, I have put a little link. If you copy and paste this link onto any browser, it will take you directly to that website to look at insulin management protocols that are being recommended for COVID positive patients at this point. So what are the challenges in outpatient management? So the first thing is new patients. I can tell you the number of times I have had patients who have gotten confused about what are they actually taking at home. The most common confusion is, am I taking NPH or am I taking an NPH regular premix? So often we all ask our new patients to come in and bring their medication so that we can confirm the meds. Now we are seeing all these new patients online. So this really becomes an issue of whether what medications are they taking and are they sure about that. The second thing is lack of recent hemoglobin A1Cs. A lot of these patients have not been to a lab in the last 3 to 4 months. So you don't have a recent A1C. You don't know where their renal function is. So you're a little bit stuck as to what to believe, whether you're believing their finger sticks, which might be few and far between, or are you going by their last, which might not be the latest hemoglobin A1C. The inability to download glucose monitors or continuous glucose monitors at the visit. So I'm sure all of your offices have things like Diasend or Gluco to download these glucose meters and look at the printouts. And you don't have that ability, at least if you're doing this remotely, if you don't have the right tools, you would not have the ability to look at their readings. Sedentary lifestyle and access to the pantry. I think this is the biggest block in diabetes management, especially outpatient at this point. I can't tell you the number of patients who have gained weight in my practice and have higher blood sugars, whether it is due to that they're sitting at home or whether it's because their kids are sitting at home. I know I am the one who's baking cupcakes in my house for my two kids who are really bored. So yes, and I'm eating them as well. So something to think about when you are treating diabetic patients at this time. Loss of insurance. I think the newest data that came out of CNN today was that 14% of the US population is unemployed at this point. So we are definitely dealing with loss of insurance and limitation of the medications we can give them. And the last and the most important thing is at this time, the need for intensification of metabolic control as a means for primary prevention of COVID disease in our diabetic patients. From here on, this is going to look a little bit like a tech presentation, but that's because there is a lot of technology that has changed in the diabetes arena in the last 5 years. And in this pandemic, we are really making use of that technology at this point. So in new patients, I am asking them to bring all their meds and show it to me on the screen so that I can see what exactly they're taking. I have asked them to write down their blood sugars, and I'm looking at their blood sugar logs. Some of them, the way we do this, and this is more of a practical tip, is I make a little table in my note and I plug in their blood sugars as they tell me so that I have an idea what their trends look like in the last 7 days. Then I'm doing quite a bit of remote meter downloads. Now, the problem with glucometer downloads is you need a tech-savvy patient. And we all know that diabetes is, well, it used to be, now it's not, but you do tend to see a majority of older patients with diabetes. Patients who might not be tech-savvy, who might not have a smartphone, or who might not have a computer hookup capability. But if you have a younger patient, there are apps that they can download on their phone that will help them email or text you the data. So these are the common meters that most of your patients have. One Touch Vario, One Touch Ultra, there's the One Touch Reveal mobile app, the AccuCheck meters, which is the AccuCheck Connect app, True Metric or True Track. This is one of the, as I call it, more insurance covered, but also a slightly cheaper and not so accurate meter. Unfortunately, has no remote downloading capability. And then Rely On, which is the Walmart brand available without a prescription meter. A lot of my patients have it. You can see more use of this because it is the cheapest meter in the market, especially with no insurance. Some of the versions are compatible with the Rely On Life app, but not all of them. What I'm going to do at this point is I'm going to play a little video that shows you what your patient is seeing on their smartphone with an app like this. So I'm going to stop sharing this presentation and I'm going to switch to the video. All right, here you can see what your patient is seeing. So this is the AccuCheck Connect Diabetes Management. And here you can see that the patient has this ability to actually look at trends, structure tests, download their settings and set an online account. So this is what the patient is seeing on their phone in terms of trends. They can change it to last 3 days, last 7, last 30 days, or a custom. You can clearly see this patient is going up and down on their sugars. So the way they share their data is first they put in their personal information. I'm going to advance this just a little bit to save time. And once they put in their personal information, then they can share the data. So here you can see they have the ability to send the data over, whether it's an email or a text message. So your medical assistant or the nurse who works with you can contact these patients, give an email address, and then the patient can send this blood glucose trend report, let's say for the last 14 days, to your nurse so that it's available for you for review during the office visit. I'll honestly tell you, when looking at this remote data versus looking at what the patient is telling me during an office visit, what their numbers are, this is much better data that I see. I also tend to find patients who are not checking as much as they think. So this is a great way of actually encouraging them and telling them, this is what I'm seeing on a download, but this is what you're telling me. So there seems to be some disconnection. It's a good idea for you to start checking your blood sugars more often. I'm going to go back to my PowerPoint at this time. All right, and we're going to advance back. Okay, so these are the freestyle Libres that are available as an outpatient. So your practice can have something called the LibreView professional account. I put in a link to this, and once your practice opens it, the patient has the ability to actually send the data directly to that. I'm going to give you an example of how we do this. So this is a little smart phrase my medical assistant has. So what she does is she actually scans through my patients a week in advance and looks at what device the patients have. The way we have done this workflow in my practice is we have the ability to put a little sticky note in our charts. And in the sticky note, we have started putting in what devices do the patients have. And depending on the device, the nurse or the medical assistant can send this my chart message where they tell them how to share their sugar readings. I have whited it out, but there's an ability to put in a practice ID here, and they can choose this practice ID on their end and share the data with you. It seems pretty straightforward, but we have put in a little YouTube link in here as well so that the patients know what they are doing. And this really helps us where the MA can then print out the data, or in some cases to save paper, snip out the data and put it in a phone encounter and send it to me. And I can look at the data when I'm ready to actually talk to the patient. So this is a really great device that is used and really helps us manage outpatient diabetes a lot better. Now, what if your patient does not do that? What if they do not want to do the uploading or the downloading? The Libre device is very useful that the reader has these reports that they can see. I have had a lot of patients who have just turned the reader to me on the screen and showed me what it is seeing. So these are actually what the readers show. So the readers can show low glucose events. It can look at daily patterns. It can look at average blood glucose. If they have a smartphone, it tells them time in range. So time in range is how much time out of 24 hours are they spending in a good blood sugar range. Most of the blood sugar range that is divided in these devices are 70 to 180 is considered good, less than 70 is considered hypoglycemia, 180 to 250 is high, and over 250 is very high. So they can really tell you a lot, even if they are unable to download the data to your practice as to what their blood sugars are doing. I'm using the Libre more and more in my practice, and insurance coverage has been average, I would say. Just for all of you who do primary care a lot and do want to prescribe this device for private insurances, it's $75 out of pocket if it's not covered by insurance for 2 sensors. And 2 sensors means 28 days because 1 sensor lasts 14 days. So it really gives a good idea to the patients what their sugars are doing. And this is the way you can have the data as well. I think in the interest of time, I'm not going to go over another video, but I put in a little link if somebody is interested to see what the patient is seeing on their phone with this. Moving on, the Dexcom continuous glucose monitor is another one that is used. This has a little Clarity app that you can use, and the patient can send the data to you. Your practice can use a Dexcom Clarity for health professional account and can look at the data on your end. Now, the tech part of the presentation is over and we move back to the science. And here is what we are doing in terms of changes in management in patients who are positive at the time of, who are positive with the infection. Metformin, you have to think about dehydration, lactic acidosis, and renal function. SGLT2 inhibitors, think about risk of dehydration and DKA. avoid initiating therapy during respiratory illness. Sulfonylureas consider risk of hypoglycemia because of poor appetite. GLP-1 receptor agonists, again, dehydration, poor appetite, inadequate fluid intake is an issue with GLP-1s. DPP-4 are probably the best tolerated during infection, although the dose might need to be adjusted for renal function, and then insulin therapy should not be stopped and should be continued. So what are the current controversies with comorbidities management? One of the big things was ACE inhibitors in COVID-19, and the American College of Cardiology, the Heart Association, the Heart Failure Society of America all said on March 17th about continuing ACE and ARBs. I'm not going to belabor the point because I know Dr. Raina explained it very, very well in his webinar. And we have one of our esteemed authors on our webinar today of the Cleveland Clinic study of Ohio and Florida patients, where they showed there was no increased risk with ACE and ARBs for COVID infections. There was another retrospective multi-center study from China that showed that people with ACE and ARBs actually did better versus patients without ACE or ARBs in terms of mortality. DPP4 is an endopeptidase with a cellular membrane receptor and is actually a functional MERS-CoV-2 receptor, but it's not a SARS-CoV-2 coronavirus receptor at this point. And there's no meaningful alteration in markers of immune function. So DPP4 should be continued during the time of the pandemic. We all know that statins do upregulate the ACE2 receptor as well. Statins are used all over the place. There has been talk enough about putting statins in the water, but we know they're important for cardiovascular and lung protection. They have shown effectiveness in terms of outcomes for pneumonia as well as influenza. And discontinuation can lead to possible rebound rises in interleukin 6 and 1 beta. So it's not a good idea to discontinue them during infection. SGLT2 inhibitors. So I just mentioned that SGLT2 inhibitors might need to be stopped because of possible risk of DKA, especially euglycemic DKA. But incidentally, dapagliflozin, which was just stolen by the cardiologist from endocrinology recently, it just got approved, I think, yesterday for heart failure, irrespective of diabetes, has actually been launched in a study called the DARE-19 study, where they're looking at it decreasing the risk of cardiovascular complications in patients with COVID-19. So this will be something to watch out for. This is more of a resource for all of you. This is a link to a sample letter from the ADA for healthcare professionals who want to be away from frontline clinical duties. PPE definitely is a requirement for healthcare professionals with diabetes. And I'm writing a lot of these letters to get them off the front lines if possible. A couple of words about obesity and COVID-19. We know obesity is an independent risk factor for increased severity of infection. We know that BMI does play an important role in respiratory mechanics, and patients with obesity tend to have a low-grade inflammation as well as aggravated insulin resistance. There have been changes in obesity management. Virtual visits for dietitians, which are covered, is a big thing for patients who have not been able to see a dietitian before. There has been loosening of constraints around controlled substance prescriptions. So phentermine can be prescribed on a virtual visit. It was not the case earlier. Unfortunately, our patients have weather-dependent outdoor activity because all the gyms have closed. So this is something that we are looking at that is causing changes in how we manage obesity as an outpatient. One of the things I'm asked by a lot of my patients is what I am doing to keep my hand out of the cookie jar. And this is what I'm doing to keep my hand out of the cookie jar. You really cannot do cross stitch on white Ida cloth if you have hands dirty with snacks. So at this point, I'm going to end my presentation. Thank you very much for the opportunity, Bijadi, Rupesh, and Dharmesh and the APNU leadership. I would like to acknowledge some people from my institute, Bart Bergera, who has been leading us through this pandemic, Cecilia Lansing, who is the inpatient diabetes head of CCF, Lauren Bueller, Danny Deemer, Shannon Knapp, and her Department of Diabetes educators, Lisa Bartlett, Julia Blanchett, as well as the Endocrine and Metabolic Institute. Thank you very much, and I'm open to questions.
Hi, Dr. Makin. This is Sulaisha. I'm practicing endocrinologist in New Jersey. It was a very good presentation, and I have a question. I mean, you had uh, a very thought-provoking idea about managing inpatients' blood sugar with Freestyle Libre.
Yes.
Now, my question is that patients with the DKA or the high blood sugar, where we know that the MARD of Freestyle Libre is already 11.4%, and it is already checking the blood sugar and interstitial fluid.
Yes.
So when you were using it Freestyle Libre, do you have any blood sugar cutoff where you just adjust the insulin drip based on just Freestyle Libre number?
So we are not using the Libre in DKs. We are only using the Libre in patients who are either on oral hypoglycemics or on subcutaneous insulin. And yes, the Libre tends to be more accurate. I would say somewhere between 70 to 250 or 70 to 300. Anything more or less than that, it tends to be inaccurate. So we are not using it in DK. In DK, we are sticking with our finger sticks for patient safety. So as I said, it's just used for subcutaneous insulin protocols.
And do you base a correction scale based on that Freestyle Libre reading
Yes,
when you are
we are
using?
doing the correction scale. We are not, if we have to confirm every Libre reading with a finger stick, it kind of defeats the point of the Libre. The Libre, as you know very well, does kind of have this thing, this message where it says if the symptoms don't correspond, or sometimes it will say you need to do a finger stick, this is not reliable. And then we, of course, do that. But we are basing the sliding scale off the Libre. We are not doing a finger stick to confirm that. But again, we are using it in more of those stable hospitalized patients versus very critically ill or DK protocol.
Okay, thank you.
All right, so if we have no more questions, I'm going to stop sharing my presentation and hand it back to Rupesh. Thank you, Rupesh.
Thank you.
Thank you. Thanks a lot, Dr. Makin. So the next presenter is Dr. Prakash Chand. Dr. Prakash Chand is actually a hospitalist, and he's the inpatient director in Worcester. And he's also additionally trained as a hepatologist. So he practices as a hepatologist and also as internal medicine. And he has been in a forefront in the Worcester with the patients with COVID-19. So I think his experience will also add to his lecture. And he's going to present about liver and COVID-19. Dr. Prakash Chand. Dr. Chand.
Can you see my screen?
Perfect. Go ahead.
Thank you. Thank you, Rupesh, for a nice introduction. I feel honored to give a talk and share my thoughts on this liver and COVID. So let me just. So I will start with the CDC, the indications for the high risk for severity of illness of COVID-19. And it says, what I did, I just flipped over the last point. That's the fourth bullet on the CDC indication for the high risk of the severity of illness. They say it's patients who are severely obese, like BMI more than 40, or who are comorbid like diabetes, chronic liver disease, or CKD, particularly on dialysis. My friend Rupesh has already presented talk on the dialysis. So I just wanted to emphasize this point that people who have chronic liver disease or cirrhosis, they are high risk, and they should be taken care of very efficiently. And other indications we're well aware of, age more than 65, so I won't go in detail. I'll move to the next. Sorry for that. So before I present, I just want to give a brief introduction about this, the LFT. Actually, the LFT is renamed in 2019, and now the all liver bodies like ASLD, American Association of Liver Disease, EASL, European Association Liver Disease, and Asian, they have changed to call a liver biochemistry test, or in short, I abbreviated as LBT, or in general, we all call it liver test. And my headings is the evaluation of patients under outpatient, and second is inpatient, who are more serious, like decompensated cirrhosis, liver transplant patients, post-liver transplant patients, and medical management with COVID-19. And most of the patients, especially liver transplant and also the kidney transplant patients, are on the, on the immunosuppressant agent. So it's a big question right now, how to manage these patients. So this is the first, like what the SARS-CoV effect on the liver. But before that, I just want to give a brief idea about the acute liver injury. Acute liver injury, we call it if there is increase in the transaminases, AST, LT more than 3 times upper limit, or GGT, or total bilirubin, or alkaline phosphatase, they are the cholestatic enzymes, more than 2 times upper limit, then it's called acute liver injury. And it happens if we consider like in 2 weeks, that's called acute liver injury. And the basis of what we call it drug-induced liver injury, that is DILI, if you have more hepatocellular with respect as compared to cholestatic enzymes, we call it the hepatocellular pattern of injury. If it is more cholestatic than the hepatocellular, we call it cholestatic. And they're both like transaminases are more than 3 times upper limit, and cholestatic more than 2 times, we call it is mixed. So with that brief introduction, I was just want to share this effect of SARS-CoV-2 on the liver. As you all know, and has been well spoken by the previous speakers on the ACE2 receptor, so I won't go in detail. It's mainly found in the liver and biliary and the glomerulus, and also is found in the testis and other alveolar epithelium. Next, I looked into the most of the studies, about like 10 studies, and some of them in our country, in California, New York. They have mainly the range of the transaminases or liver tests are between 14 to 53% of the patients have elevated liver test, and most of them have 3 times upper limit. So it's mainly the as incidence is between 14 to 53%, but if you count the prevalence, it's about 76%. And liver disease is more common in more severe COVID-19 cases than the mild cases, and rarely it can cause acute liver injury, which is very serious. And this severe COVID-19 is uncommon in children and is less likely associated with elevated liver test. So out of all these studies, I've selected this study to share some of the salient features. This study is characteristics of liver test in COVID-19, and it was published in a Journal of Hepatology in just about 2 weeks ago. This is the EASL study, European Association Study of Liver Disease. What they did is mainly they have 417 patients, and they followed from for a period of 6 weeks. And what they found that 318 patients, that is 76%, had abnormal liver blood test, and 90%, about 25% had liver injury during this hospitalization, like about period of 6 weeks. And patient with abnormal liver blood test and liver injury, those found at the time of admission, they had the higher risk of progressing to severe COVID-19 pneumonia. And that study found about 26%, or I'll say just about a quarter of them progressed to severe pneumonia. About 21% they developed severe COVID-19 disease, and 78% had a mild disease during the hospital course. And about the pattern of the liver injury, they found it's mainly hepatocellular or mixed type. But in this study, they found more of mixed type as the pattern. And when they did the odds ratio, it was 4.4 for the mixed type, and for hepatocellular, it is 2.73%. This mixed type, I think it's most probably because they use this lopinavir, ritonavir as the treatment agent, and 80% of their patients were on these medications. And this increases the risk for about fourfold. Next, I just summarize this study in the form of table. If you see here, this blue is the total number of confirmed cases, and this brown is abnormal liver test, and this gray is acute liver injury. So I just want to emphasize one point, that out of this total of 90 patients who had acute liver injury, and out of them about half, like 46%, they progressed to the severe COVID-19. So in that, it points us to that this abnormal liver test or acute liver injury during the progress of the progress of disease is a marker of the, or predictor of the severity of COVID-19. And this acute liver injury mainly happens in the first 2 weeks of the hospitalization or of the disease. And the second part of the picture, sorry. Oops. Sorry. And the second part, it's just, I don't want to scare you, but it's just on the y-axis, it's odds ratio, and on the x-axis is the medications mainly that used in the COVID-19. It's antibiotics, and in China, they used herbal medications, and it's lopinavir and NSAIDs, oseltamivir, and ribavirin. I just want to draw your attention with this one, which is the graph for the lopinavir. All of this touch the odds ratio 1, and as we all know that if odds ratio is 1, it doesn't meet the statistical significance. But this was very statistically significant, and the p-value was less than 0.01. So this tells us that this lopinavir is mainly reason for the severity of liver injury in that particular study. And now this is out from our treatment armamentarium. Now I want to go back to the should we look for, and what are the markers for the severity of the liver disease, which in turn is a predictor of severity of the COVID-19. If you have a low serum albumin, which is new, then it's a marker of the COVID-19 severity. And general pattern we already discussed. So next, the liver test abnormality, it is used as a predictor of the severity of disease. And it says that as, in severe, it increases the severity of disease by about 9-fold. Or about quarter of the patients progress to the severe pneumonia. And most of the time, even though liver histology was done in only one patient or few patients because of this pandemic, it mainly ranges from moderate microvascular stasis to mild lobar portal activity. Rarely you get a focal necrosis in the portal area. Now this is the big question. Is it a cause or effect? What is the relationship between COVID-19 and elevated liver blood test, and how we should read it? So either the acute liver injury or elevated liver blood test, is it a direct viral cytotoxic effect, or is it secondary to inflammatory response of the disease itself, or it's the hepatotoxic? And as I say, my friend Rupesh, he deals with the kidney, and I feel like liver and kidney runs together, and it has the job of detoxification of the most of the medications, and liver being the metabolic organ, it has a job to for detoxify and excrete the all the medications, especially all the therapeutic agents, which I'll come later. And second, still this chronic liver disease. We don't know, are they more susceptible to the severe liver injury, or they are more susceptible to the severe COVID-19 pneumonia? So it's hard to find the direct relationship. And also it's unclear whether this virus, do they exacerbate this cholestasis, or mainly in the primary biliary cholangitis or PSC. But as the previous speaker and other first speaker, also Dr. Neil Mehta, he very nicely illustrated the point of ACE inhibitor and ARB. So I won't go in detail, but just as per liver's perspective, this ACE and ARB in the study didn't show any difference for severe disease as compared to other antihypertensive like amlodipine. But in the beginning, like at the time of admission, it does causes increase in the abnormal liver blood test, but that increase has not met to the statistically significant. So it maybe have a minor effect. These are some of the recommendations from the ASLD and EASL, that European Association of Liver Disease, and I have summarized here. So we should test for hepatitis B and acute viral panels, C and A in the patients of COVID-19 who have elevated liver blood test. And we avoid unnecessary imaging if it's not needed, unless there is strong clinical suspicion of biliary obstruction or cholangitis. I just had one patient who is a cholangiocarcinoma, and he's not a candidate for liver transplant. He has a big mass in the node, and he came with a cholangitis about 2 days ago. And so it's very important regard the imaging. And third bullet is a patient with elevated liver test should still be considered for off-label therapeutics. That will come later on the therapeutic section. So if you have a elevated liver blood test, they are not barred from the treatment. And don't assume autoimmune flare or rejection if you find a patient with elevated liver test. You have to still find the basic causes. And we monitor the liver test in all our COVID patients every day, especially if they are treated with this remdesivir or tocilizumab. And in children, I will say that patient with elevated liver blood test, we don't assume that it is COVID-19, but we all have to think from the beginning regarding what are the underlying liver disease and what should be the cause. For coming to the next, like how should we evaluate our patients as an outpatient or in the clinic? The patients who are hepatocellular cancer, are they increased risk for severe COVID-19? At this time, it's not clear, it's early to say. And the second thing is the patient who calls you like for the jaundice or who have elevated transaminases more than 500 or recent decompensation. I will say that please send those patients directly to ER. They don't have to come to even office. And Dharmesh, he already illustrated about this importance of telemedicine and phone visits. And it's very important for triaging those patients and cohorting before even they enter into your clinic. And next, the liver transplant clinic or hepatology clinics, those patients, especially who are cirrhotics, they're immunocompromised. So I'll say we don't evaluate in person those patients in the clinic, but it's more telemedicine. And regarding the treatment for hepatocellular cancer, I will just say, please review the image with the tumor board before even scheduling the patient visit, so that you have a plan before what to tell to the patient and plan it accordingly. Regarding the surveillance for imaging, we do the usual surveillance like for hepatitis B, C, and cirrhosis, the surveillance like every 6 months with ultrasound or CT scan. We do the same thing, but if there is a delay of 2 months, it's okay. Now I shift to get to the more complicated patients who are decompensated cirrhosis, liver transplant, eval, or post-liver transplant. So the effect of SARS-CoV-2 in patients with chronic liver disease, decompensated cirrhosis, or people who are awaiting for liver transplant on list, it's still unclear how is its effect, and it's very uncertain time. So only the time and the more studies will tell us. And the people who are COVID-19, those who are on the list, they become automatically ineligible for organ donation. So both recipients and the donors have to be COVID-19. And to my surprise, I must admit that I just recently found that transplant surgery comes in the tier 3B as per CMS. What it means that we don't have to postpone it. But the real big question comes here, what to do them during this pandemic, because we all know about the PPE utilization, and there is how to safely utilize our resources. And all these transplants are a big surgery. It anywhere takes between 8 hours to 12 hours. And if there is dual transplant like a liver and kidney, it might take about 16 hours. So are we ready for this transplant? And then the post-transplant period comes, especially the first 2-3 weeks, where it needs heavy dose of immunosuppression. So it's a big question, and we don't have the clear answer. The ASLD tells that it needs more institute-based policy making, ethics consideration, and it becomes a big administrative question. Now I move to post-liver transplant patients. As an internist, and most of us have patients who are post-transplants, so what to do with them? So the liver transplant recipients who are more than 60 or immunosuppressed are very vulnerable or high risk for this SARS-CoV-2 infection. And it looks like, but it's early to say that immunosuppressed patients, what is the risk for the severe COVID-19? But I will say it's definitely a greater risk as we are coming to more know about this severity of COVID-19. And these immunosuppressant agents definitely prolong the viral shedding. And again, all the speakers have emphasized on these prevention measures, minimize in-person telemedicine. And for the patients who are on the immunosuppressants, I will say please excuse them or give some work off from their work, but still they can do the telework, and definitely, needless to say, advise against travel. So how to manage this immunosuppressant agents? The effect of immunosuppressant agents on the COVID-19 are not well established, it's not well understood. So mostly we say that you have to reduce the dose of this immunosuppressant agents, but don't stop it, because it may flare the autoimmune hepatitis or precipitate the acute rejection. So, but this ASLD, another, doesn't tell you how much we have to reduce it. Is it to be a quarter or half? Because there are several factors to control the dosing of immunosuppressant agents. First of all, at what stage the post-liver transplant patient is. Is it like an early, like within a month or 6 months or year or 2 or more than 5 years? I will just say the best way to go will be to call the transplant coordinator or transplant team of that patient and make a plan, because we have to monitor the several side effects, including clinical like neurotoxicity and also the level of the calcineurin inhibitors like every 2 or 3 days, along with the common labs like CBC, CMP, and magnesium, because these are prone to cause nephrotoxicity, hypomagnesemia, acute liver injury. So it's a challenging task to manage this, and its best can be done in it's like a co-management with the transplant coordinator or transplant team. Again, all the liver bodies and WHO recommends avoiding corticosteroids unless it is indicated for another indication. And now there are two groups, like patients who are immunosuppressed who are without COVID-19. In them, it's very simple. We don't have to touch the dose of the immunosuppressant agents, so no need to reduce it. Now, the major challenge is here, the patients who are COVID-19 and immunosuppressant agents. So we consider minimizing the dose of prednisone, but still try to avoid adrenal insufficiency. And then we try to reduce the dose of calcineurin inhibitors or mycophenolate, especially in the setting if the patients are lymphopenic, fever, pneumonia, or they have severe COVID-19 or in the ICU. It becomes a very challenging task. It needs rigorous monitoring of the labs, clinical, and it's co-management's multi-specialty thing. And once again, we have to consider the starting the prednisone or corticosteroids, a new start of immunosuppressant agents. And we have to do a real risk-benefit analysis. And most of the time, we find that risk outweigh the benefits. So we don't have to start this corticosteroids or immunosuppressive agents new. Now, coming to the inpatient management, if you get a patient who has a hepatic encephalopathy, which is new onset, we always consider this COVID-19 infection. And the people who are decompensated cirrhosis, like who have liver pulmonary complications, especially if they have hepatic hydrothorax, portal pulmonary hypertension, or hepatopulmonary syndrome, it's advised to preemptive intubation or aggressive airway management. We don't wait for the last. And then every hospital, they should have developed a protocol, and I think all hospitals have those, to avoid direct admission for the patient, but it should be triage cohort in the ER, and to minimize the inpatient hospital transfer so that they should go where they should be in isolation, especially for the patients who are cirrhotics, who are immunocompromised, or people who are on immunosuppressant agents. Now, coming to the therapeutics, we all know there is no approved drug, but coming to the possible role, this remdesivir has been in use, and interleukin C, hydroxychloroquine, this antiretroviral drug, darunavir, then convalescent plasma, and favipiravir is mostly used in East China. We have not used much here. And coming to the drugs which we found no role, are kind of like contraindicated, is lopinavir, ritonavir, which I've said previously that it increases the fourfold increase in the acute liver injury, so it's a big no-no. Others are steroids, ACE and ARB, and oseltamivir. Now, coming to the medications, Vinni just said about the ACE and ARB, so I don't have to go in that. It just says like we continue the usual antihypertensive treatment, including ACE and ARB. Acetaminophen less than 2 grams is the preferred analgesic and antipyretic agent, and monitor liver tests in all patients, especially if they're treated with remdesivir or tocilizumab. This is a nice interaction table because as I said, the liver is the main metabolism organ. It has a job to detoxify all the medications, and we have to know about this drug interaction. I will just ask all my colleagues and listeners to this website, which I've written below, is COVID-19-druginteractions.org. It's on the website of the Liverpool. They have the interaction for all the different medications, starting the anti-diabetic medication, antihypertensive, all the medications. So I've just pulled up this immunosuppressant agents. It looks a busy table, but I'll just draw attention to the medications we commonly use. That's our calcineurin inhibitors, that's the tacrolimus, sirolimus, and mycophenolate. And I think cyclosporin is used as second and third tier. Rupesh will do that, and he can add anything further. And azathioprine. So if we see on this one, remdesivir, it's good thing. It does not have much great or any significant drug-to-drug interaction. So we are pretty safe here. Now coming to this chloroquine and hydroxychloroquine, we know that there is increase in the level of the immunosuppressant calcineurin inhibitors, tacrolimus, and we have to watch for this QTC interval. So all this found in the tacrolimus, sirolimus, cyclosporin. Now coming to this last one, tocilizumab, it's opposite effect that it decreases the level of these immunosuppressant agents. So I think next I will come to this the safety issues of the medications, the common medications we are using these days. We are mainly using remdesivir these days, and it's for moderate to severe pneumonia or COVID disease. And the safety issues are, if the GFR is less than 30, we have to be very careful, or it's kind of like contraindicated. And also the acute liver injury, if the transplant are more than 5 times upper limit. And the common side effects is nausea, vomiting. And we all know this point that Dr. Fauci has said that in the interim analysis of the trial, they found that it met the primary endpoint, and the time to recovery in the treatment arm is 11 days versus 15 days. As other drug. And the mortality has also improved 8 versus 11%. And lopinavir, let's skip. We said it's a big no, and it has more toxicity because it's CYP3A inhibitor. And hydroxychloroquine, we all know it's a QTC prolongation. Beyond that, it also causes cardiomyopathy and 6-GPT and myositis. For this drug, tocilizumab, interleukin-6 receptor antagonist, it's found that it mainly causes the pancytopenia, so we have to be careful on that. And rarely, like in less than 1%, it also causes acute liver failure, which is very dangerous. Some of the patient might need liver transplant too, so it's we have to be very careful. And then the convalescent plasma, which is in the news for patients who are very seriously ill or in the ICU, its potential safety issues are trally or anaphylaxis. Patient needs to be in the ICU, and challenge is that we have to screen for the other transmissible pathogens. The dose right now it's not clear. Is it like 400 ml in some use in 5 patients, and third they use 200 ml infusion in 10 patients. And finding the donors with neutralizing IG activity is still not established. Coming very briefly on the procedures, I'll say the endoscopic procedures are considered aerosol generating, so we'll cancel all the elective and non-urgent procedures, which includes endoscopy, liver biopsy, and fibroscan. Certain life-saving or essential procedures can be performed, like liver biopsy if it is done for AIH flare-up, or we don't know what's going on, or for the acute graft rejection. For therapeutic paracentesis, tips for bleeding, variceal bleeding, or other biliary procedures. The patient has cholangitis. And I think that's my last slide. Thank you very much. I'm open to the question.
Thank you, Dr. Chan. So I will open the short question answers. Anyone has any questions?
Very complex presentation, very difficult topics, nice presentation. Seems like there's no way, whatever you do at this point is difficult one to handle. Hopefully we'll get some answers as time goes by.
Thank you, Dr. Malala. Anyone else? Any other questions, input? It was very nice presentation.
Thank you.
Thank you.
I just want to remind that we have next presentation on Sunday, on 10th at 7 p.m. And then we also have our event, Kailashkar event next week on May 16th from 1 to 2 p.m. So we'll sending the flyer for that too.
Thank you.
Thank you. Thanks a lot, Dr. Chan. Thanks a lot.
Thank you, Dr. Chan, for nice presentation.
Thank you.